Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, I know my history is a bit complicated with the diabetes and everything else, but lately I've been really struggling with managing everything. The late work hours really throw off my meal schedule, and I end up eating whatever I can get, which is usually not the healthiest option. It's just been really hard to maintain a good diet.
I understand that it can be challenging, especially with your work hours. Let's go over everything step by step. How have you been feeling lately in general?
Well, overall, I feel tired most of the time. My job is physically demanding, and with my erratic schedule, it just adds up. I've been trying to monitor my blood glucose at home. The readings have been a bit high, especially after meals, and with my back and foot hurting, it just makes everything more stressful.
You mentioned your back and foot pain. How often do you experience these pains, and have you noticed anything that makes it better or worse?
The back pain is almost daily, especially after a long day at work. As for my foot, it hurts mostly when I've been standing for too long. Nothing seems to really help, just resting when I can.
And how about your diet? Can you tell me a bit more about what you typically eat in a day?
It's not great, to be honest. Because of the hours I work, I usually miss regular meal times. I end up grabbing fast food a lot, and I have a real sweet tooth. I know it's not good for my diabetes or cholesterol.
Let's talk about your medications now. Are you currently taking all your medications as prescribed?
I try to, but sometimes I miss doses. I ran out of the terazosin for my nocturia and need a refill. The muscle relaxant helps a bit with the neck spasms, but doesn't do much for my other pains.
It's important to take your medications regularly to manage your conditions effectively. Now, regarding your mental health, how have you been feeling? Any anxiety or stress you want to discuss?
Yes, I've been feeling quite anxious lately. The stress from work, my health, and just managing day-to-day life has been a lot. I used to take medication for my anxiety, but I stopped. I think it's getting to the point where I might need some help with that again.
Thank you for sharing that with me. It's important that we address your mental health as well as your physical health. We'll make sure to discuss this further with the psychiatrist. Now, let me go over today's results and we'll make a plan moving forward. Based on today's evaluation and the lab results, here's our plan. Your A1C has improved slightly to 7.2%, which is good, but we need to continue working on your diabetes management. Your fasting blood glucose today was 130 milligrams per deciliter, which is a bit high, and your postprandial glucose is also higher than we'd like at 180 milligrams per deciliter. We'll continue with the metformin, and I'm going to refer you to our dietitian to help with meal planning around your work schedule. Your blood pressure is well controlled at 120/80 mmHg, which is excellent. However, your cholesterol levels are still a concern, particularly your LDL at 140 mg/dL. We need to adjust your rosuvastatin dosage. I'll also add a medication to help better manage your cholesterol levels. Regarding your musculoskeletal issues, I'm referring you to a podiatrist for your foot and will continue your current regimen for neck spasms. For your nocturia, I'll refill your terazosin and monitor how you're doing with it. Your glaucoma needs regular monitoring, so I'm scheduling you for an eye exam with our ophthalmologist. Lastly, I'm concerned about your anxiety and how it might be affecting your overall health. I'm going to arrange for you to see a psychiatrist to reassess your mental health and discuss possible treatments. It's very important that we take a comprehensive approach to your health, considering all these factors. Do you have any questions, or is there anything else you'd like to discuss about the treatment plan?
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
I've been feeling quite off lately, and I think it's a mix of everything happening. First, there's the loss of my dad a few months ago, and it's been hitting me hard. I find myself up late just thinking about him, and it's been tough to get a good night's sleep.
I'm sorry to hear about your father. It's important to discuss these feelings, and I'm glad you brought it up. How have these feelings been affecting your daily life?
Well, apart from the sleep issues, I've been feeling really down. I guess that's affecting everything else too. My wife and I have been trying to have a kid for over a year now with no luck, which only adds to the stress. We're both really concerned about potential fertility issues on my part.
Thank you for sharing that. It's not uncommon for stress and emotional strain to impact your overall health and potentially your fertility. Have you seen any professionals about your mental health since your father's passing?
Yes, I'm currently on valproate and citalopram for my mental health. I've been on these meds for a while now, for depression and mood stabilization, but sometimes I feel like they're not enough with everything going on.
It's good that you're on treatment for your mental health. Managing your medications and ensuring they're still effective is something we should keep an eye on. Now, regarding the fertility issues, can you tell me more about what you and your wife have tried so far?
We've basically been trying naturally, just hoping for the best. But after a year with no success, we're starting to worry. I haven't had any tests done yet, so that referral for a semen analysis you mentioned sounds like the next step we should take.
That's a sensible next step. A semen analysis can provide us with a lot of information about your sperm count and health, which is crucial for assessing fertility. In addition to this, we'll want to consider how your physical health, including your recent weight gain and the medications you're on, could be affecting your fertility.
Yeah, my weight has been an issue. I've been trying to eat healthier, and I thought about starting to exercise, but I haven't really gotten into a routine. I know it's important, especially now.
Getting into a routine can be challenging, especially during stressful times, but incorporating some regular physical activity could help with your weight and improve your overall health, which in turn might positively impact your fertility. Have you had any other health concerns lately? Any issues with constipation or swelling in your legs?
The swelling in my legs isn't new, but it's been more noticeable lately. I manage to keep the constipation under control with fiber supplements most of the time, but it's still a bother now and then.
We'll keep an eye on that swelling in your legs as well. It's good that you're managing the constipation. Maintaining a balanced diet will help with that and your weight management. Now let's go over some of your clinical values from today's tests to get a clearer picture of your overall health status.
Please go ahead.
Your body mass index is currently at 29, which classifies you as overweight. Your fasting blood glucose level is 102 milligrams per day, which is just above normal. Your total cholesterol is 210 milligrams, LDL cholesterol is 140 milligrams, and HDL is 40 milligrams. Your triglycerides are at 180 milligrams per day, indicating that we need to work on lowering these numbers. Your liver and kidney function tests are within normal ranges, and your thyroid function is also normal. Now, concerning your blood pressure today, it was 136/74, which is manageable with your current regimen.
Okay, that's a lot to take in. What do you suggest we do moving forward?
For now, I recommend continuing with your current medications. I'll order a fasting lipid panel and a PSA test along with other routine labs to keep an eye on your cholesterol and overall health. The referral to urology for a semen analysis will be processed today, and you should hear from them soon. It's crucial that you try to incorporate more exercise into your routine and continue to focus on a healthier diet. These changes can make a significant impact on your cholesterol levels, weight, and potentially your fertility.
Thank you, doctor. It sounds like a solid plan. I'll start working on those lifestyle changes right away.
That sounds great. Let's schedule your next appointment for 3 months from now, on a Friday, to follow up on all these points. Please make sure to complete the fasting labs as soon as possible.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Good morning, everyone. Let's quickly go over the surgical plan for today's procedure, which is more complex than usual.
Yes, Dr. Simmons. I've reviewed the patient's latest scans, and it seems the tumor has slightly shifted since last assessed. We need to adjust our approach accordingly.
That's correct, Dr. Lee. I propose using the lateral entry point as it provides better access to the tumor without affecting the surrounding structures. Any thoughts on this?
Agreed. I've prepared the surgical tools that are specifically designed for this type of entry. Also, let's ensure we have real-time imaging available to monitor the tumor's position during the procedure.
Excellent point. We'll use intraoperative MRI to guide us. Also, anesthesia. Are we prepared for a possibly extended surgery time?
Yes, Dr. Simmons. We're ready for any adjustments needed during the surgery. I'll monitor the patient's vitals closely and keep you all updated.
Now look at question 26.
Today we'll explore non-pharmacological approaches to pain management. It's crucial we consider these options, especially for our chronic pain patients.
Absolutely, Dr. Jenkins. One approach I find promising is the integration of acupuncture. Studies show it can significantly reduce pain for some patients without the side effects of medications.
True, and let's not overlook the benefits of physical therapy and exercise regimes tailored to individual needs. These can improve mobility and reduce pain perception over time.
Mindfulness and cognitive behavioral therapy are also excellent tools. They help patients manage the psychological aspects of chronic pain, which can often exacerbate physical symptoms.
I agree, and we should also discuss these approaches in our patient education sessions. The more informed our patients are about their options, the better they can manage their pain.
Now look at question 27.
Let's focus on creating a comprehensive child care plan. Our goal is to address the medical, psychological, and developmental needs of the child.
Firstly, the child's medication regimen needs to be thoroughly reviewed. We want to ensure that all prescribed treatments are optimizing his health without unnecessary side effects.
Absolutely. We should also integrate a dietary plan tailored to his specific needs to support his overall development and manage any allergies or dietary restrictions.
And on the psychological front, regular assessments with a child psychologist should be included to monitor his emotional and cognitive development.
Indeed, and let's not forget about the educational aspects. Collaborating with educational therapists can provide him with the necessary support to succeed in school.
Now look at question 28.
I understand you've been experiencing pelvic pressure lately. Can you tell me more about your symptoms?
Yes, it's been quite uncomfortable, especially towards the end of the day. It feels like a constant heaviness.
It sounds like pelvic congestion syndrome, but we'll need to conduct a few tests to confirm. In the meantime, there are several management strategies we can try.
What sort of strategies?
Pelvic floor exercises can be very effective. Also, wearing compression garments can help alleviate the pressure. Have you tried any of these methods before?
No, I haven't, but I'm willing to try anything that might help.
Now look at question 29.
Let's debate the benefits of a sterile clinical environment. While it's crucial for preventing infections, I believe it can be too isolating for patients.
I see your point, Dr. Carter, but the primary goal in clinical settings is to reduce infection risks, especially in areas like the ICU, where patients are extremely vulnerable.
True, but we must also consider the psychological impact on patients. An environment that's too clinical can feel cold and unwelcoming, potentially affecting a patient's recovery.
Perhaps the solution lies in balancing strict sterility with elements that make spaces feel more welcoming, like artwork or more comfortable furnishings that are also easy to clean and disinfect.
That's a good compromise. Integrating design elements that support both the physical and emotional health of our patients can certainly provide a more holistic approach to healthcare.
Now look at question 30.
I understand you've been having some gastrointestinal issues recently. Can you describe your symptoms?
Yes, doctor, I've been experiencing abdominal pain, bloating, and irregular bowel movements.
These symptoms can be quite bothersome. Let's discuss some dietary adjustments that could help manage these issues. Have you tried a low FODMAP diet?
No, what does that involve?
It's a diet that eliminates certain carbohydrates that are poorly absorbed by the gut. Many patients find relief from their symptoms by following it.
That sounds helpful. Could we try that approach?
Absolutely. I'll help you get started, and we'll monitor your symptoms closely to see if it provides relief.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at extract 1.
Welcome to our healthcare talk on the management of hypoglycemia in hospitalized adult patients in non-critical care settings, based on the latest 2022 guidelines from the Endocrine Society. Today we'll delve into the intricate details of these guidelines, providing a comprehensive understanding of their development, recommendations, and implications for clinical practice. Additionally, we'll explore a relevant case study to illustrate the practical application of these guidelines. The Endocrine Society recognized the need to update their 2012 guidelines due to the vast amount of new research and evidence that has emerged over the past decade. The 2022 guidelines were developed using the GRADE process, a rigorous methodology endorsed by the Institute of Medicine and utilized across various medical disciplines. This process ensures that recommendations are based on the best available evidence, combining expertise from McMaster's University and the Mayo Clinic. A significant update in the 2022 guidelines is the inclusion of recommendations regarding the use of insulin pumps and continuous glucose monitors, CGMs, in the hospital setting. Historically, the use of these devices in hospitals has been controversial. Many hospitals have been reluctant to allow patients to use their own devices due to concerns about safety and staff unfamiliarity. The guidelines now recommend that patients be allowed to use their insulin pumps in the hospital, provided they have the mental and physical capacity to manage them. Furthermore, it is essential to have personnel knowledgeable in insulin pump therapy to support these patients. For continuous glucose monitoring, the guidelines acknowledge that while these devices are not yet FDA approved for hospital use, their adoption during the COVID-19 pandemic under emergency allowances has shown promising results. CGMs can reduce the frequency of hypoglycemia and improve overall glucose management. However, their use should be supplemented with point-of-care glucose testing for making critical insulin dosing decisions. This conservative approach ensures patient safety until more robust data can confirm the reliability of CGMs for insulin dosing in the hospital. The guidelines also address the management of hypoglycemia in patients undergoing elective surgeries. It is recommended that patients achieve an HbA1c level of less than 8% prior to surgery to improve postoperative outcomes. For patients where this is not feasible, maintaining preoperative blood glucose levels between 100 to 180 mg per gL is advised. This approach helps reduce the risk of postoperative complications such as infections, cardiac events, and prolonged hospital stays. In terms of insulin therapy, the guidelines emphasize the importance of individualized treatment plans. For patients without a prior history of diabetes, but who develop hypoglycemia in the hospital, sliding scale insulin, also known as correctional insulin, can be used initially. However, for patients with a history of diabetes, or those previously on insulin therapy, scheduled insulin regimens including basal and prandial insulin are recommended. This approach helps maintain stable blood glucose levels and reduces the risk of severe hypoglycemia. A key component of the guidelines is the recommendation against the use of non-insulin therapies in the hospital, with some exceptions. For instance, DPP-4 inhibitors may be continued or initiated in patients with type 2 diabetes who have HbA1c levels less than 7.5% and blood glucose levels under 180 mg per gL. However, GLP-1 receptor agonists, SGLT2 inhibitors, and other non-insulin therapies are not recommended due to insufficient evidence on their safety and efficacy in the inpatient setting. The guidelines also highlight the importance of diabetes self-management DSME and support for hospitalized patients. Providing DSME in the hospital can lead to better glycemic control and reduced hospital readmissions. Given the shortage of diabetes educators, it is crucial to train hospital staff to deliver basic diabetes education to patients, focusing on lifestyle measures, medication management, and recognizing signs of hypo and hypoglycemia. To illustrate the practical application of these guidelines, let's consider a case study of a 55-year-old male patient, Mr. Smith, admitted to the hospital with a severe asthma exacerbation. Mr. Smith has a history of type 2 diabetes, managed with metformin and occasional use of insulin. Upon admission, his blood glucose levels were noted to be elevated, ranging between 200 to 250 milligrams per deciliter. Following the 2022 guidelines, the healthcare team decided to initiate a scheduled insulin regimen for Mr. Smith, including basal insulin and prandial insulin before meals. Continuous glucose monitoring was utilized to track his glucose levels, with point-of-care testing used to adjust insulin doses accurately. Mr. Smith was also provided with diabetes self-management education during his hospital stay, focusing on the importance of monitoring his blood glucose levels, understanding his medication regimen, and recognizing the signs of hypo and hypoglycemia. Over the course of his hospital stay, Mr. Smith's blood glucose levels stabilized, and he was able to achieve a target range of 100 to 180 milligrams per deciliter. The education he received empowered him to manage his diabetes more effectively post-discharge, reducing his risk of future hospital readmissions. The 2022 Endocrine Society guidelines provide a comprehensive framework for managing hypoglycemia in hospitalized adult patients in non-critical care settings. By incorporating the latest evidence and emphasizing individualized care, these guidelines aim to improve patient outcomes and enhance the quality of diabetes management in the hospital. The practical application of these guidelines, as demonstrated in Mr. Smith's case, underscores their relevance and potential to positively impact patient care.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
I'm glad to have you here to discuss this rather detailed clinical practice guideline in a quite complicated area of medicine. This document covers vitamin K antagonists, direct oral anticoagulants, and heparin bridging for patients with chronic atrial fibrillation, mechanical heart valves, or venous thromboembolism, and antiplatelet agents for mainly cardiac patients. There are 43 PICO questions here, with 44 guideline recommendations. I wonder, was this a difficult guideline to develop, and how did you even start?
Thanks again for the opportunity to discuss the ACCP CHEST guidelines on perioperative antithrombotic management. This was a guideline that was rather overdue because it was anchored on two previous guidelines published in 2008 and 2012. We were delighted to be able to do this because since that last iteration, we have had the direct oral anticoagulants, or DOACs, come onto the scene, and they've become the dominant anticoagulants in many clinical indications. But we also wanted to update the literature on a variety of areas, including perioperative heparin bridging and perioperative antiplatelet drug use. So it was a nice opportunity to update the evidence, and we're delighted that it finally got published in 2022.
Great. So I think we should probably start with some definitions in this very lengthy document, so we're all on the same page when we listen to the recommendations. Can you take us through the important terms for our listeners and any qualifying remarks?
Sure. Maybe what I can do is kind of provide a bit of an insider view of how these guidelines and recommendations were developed, and to allow people to understand that guideline development is a very rigorous process that has many steps that have to be adhered to. But at the end of the day, there's also a subjective element, and there are people who are gathered to want to provide the best available recommendations, but also do so in a manner, in our case, that's very practical. So for the audience, when they look at a recommendation, they have to take into consideration that it was based on direct evidence, but also indirect evidence. In other words, evidence from other areas that pertain to that general area. And then thirdly, there's also the interpretation of the studies, their strengths and limitations. Finally, it's really important to notice that the recommendations required a certain amount of consensus. So within that process, we wanted to provide recommendations about management in various clinical domains that provide clinicians with a kind of how-to approach. How do you assess thromboembolic and bleeding risk? How do you bridge? How do you integrate VTE prophylaxis? And importantly, how do you communicate and ensure that there is good consensus among the various caregivers involved in the perioperative setting? And then finally, to your point about definitions, we also wanted to define what we are talking about in terms of the patient groups. And we focused mainly on the dominant indications for anticoagulant therapy and antiplatelet therapy, which are patients who have a mechanical heart valve, atrial fibrillation, venous thromboembolism, or coronary artery disease. And of course, we defined the various antithrombotic treatments, whether they were a vitamin K antagonist, a DOAC, or an antiplatelet agent. And then in terms of the actual period of perioperative management, we define that period as starting from about 5 days before a planned surgery to about 30 days after. So again, we're looking at planned elective surgery. We did not address emergency or urgent surgery, which is a very different clinical domain and was beyond the scope of these guidelines.
It certainly sounds like a very rigorous process and a very comprehensive guideline. I think we all commend you and the panel on your effort. If it's okay with you, I might focus the initial discussion on anticoagulants. I think we're all trying to do our best with patients in balancing the risk of bleeding versus the risk of clot formation. Could you take us through the pharmacology of these drugs in relation to their clearance? I think that'll help us understand the specific recommendations.
Sure. So why is an understanding of pharmacology, specifically pharmacokinetics and pharmacodynamics of anticoagulants and antiplatelets, important? We typically don't think about it when we're prescribing these drugs, but it is very important in a perioperative setting because we want to ensure that when a drug is removed from the circulation, patients don't have an active anticoagulant or antiplatelet effect, for example, for certain types of surgery that have a high bleed risk. We need to rely on the pharmacological properties because we don't often have routinely available rapid tests in all clinical situations. Sure, you can do an INR 1 or 2 days before surgery in patients who may be on warfarin to check if there's any residual effect, but you may not be able to do that in all circumstances. Similarly, we don't have a test that we can use to measure DOACs that is widely available and reliable. And then for the antiplatelet therapy, there are not really a lot of reliable and well-studied tests of antiplatelet function. So in the absence of these widely available tests, we have to rely on both the pharmacokinetic properties and pharmacodynamic properties of these drugs. Having a basic understanding is really important for perioperative management.
So could you give us some examples of the common drugs in terms of expected pharmacodynamics?
Sure, I'd be happy to. So let's consider first of all the vitamin K antagonists. In North America and in many countries, warfarin is widely used, and we know, for example, it has a half-life of between 36 and 42 hours. On the other hand, in some countries, for example in Europe, their vitamin K antagonist is usually acenocumarol, which is very different. It has a much shorter 8 to 11 hour half-life. And then there are infrequent circumstances when patients might receive fenprocuman, which has a much longer half-life of 96 to 104 hours. So in this situation, having that knowledge of the pharmacokinetic properties, in this case half-life, is very important to determine how long you interrupt the drug. For warfarin, of course, we recommend interruption of at least 5 days based on those PK principles. Similarly with the DOACs, which have a half-life of about 8 to 12 hours, it's also important to tailor the interruption according to that half-life and according to the patient's risk. But the other part of the pharmacokinetic effect with DOACs that's really important in a perioperative setting is their onset of action. A lot of clinicians may not be aware that when you take a DOAC, its peak anticoagulant effect occurs 1 to 3 hours after oral intake. Now, that may not be important when you're starting somebody on treatment for, let's say, atrial fibrillation, but it is very important when you're resuming the DOAC after surgery or a procedure, particularly if it's a high bleed risk, because you don't want that peak anticoagulant effect to cause bleeding. And then finally, when we look at the antiplatelet drugs, it's very important to separate the pharmacokinetic and pharmacodynamic effects. So the half-life of aspirin or other P2Y12 inhibitors like clopidogrel or ticagrelor is only a few hours. But as we know, in the case of aspirin, clopidogrel, and prasugrel, these are irreversible platelet inhibitors. So once they act on the platelets, their effect lasts way beyond their half-life. Their pharmacodynamic effect is that they impair platelet function for the lifespan of the platelet, which is 7 to 10 days. It's a little bit less with ticagrelor, which has some reversibility in its antiplatelet effect. So it's really important to have a basic understanding of the PK and PD properties of these drugs to allow you to use them safely and effectively perioperatively.